is a patient having bedside ultrasound just before having a percutaneous tracheostomy. And you can see what we're doing is pressing very gently on the neck to examine with ultrasound the structures anterior to the trachea. Now the trachea is filled with air, so it doesn't transmit ultrasound very well. So you're often seeing the trachea as just a shadow or an absence of those reflected ultrasound images. But what you can often see is the skin, the subcutaneous tissue. You can usually identify the thyroid gland, and you can see where the trachea is. This allows you to make some depth measurements, so you can estimate or measure the depth from the skin to the trachea. It also allows you to identify some of those important vessels that we were reviewing on previous slides. So, for example, the carotid artery is something you definitely want to avoid. And arteries are typically pulsatile, and you cannot compress them when you squash the tissues with ultrasound probe. That's in contrast to veins, which are compressible, but they still can get in the way. So there can be anterior veins right over where you want to make your incision, but veins off to the side are usually ones that you can avoid. If we turn the probe through 90 degrees and look longitudinally, you can identify the trachea in a longitudinal plane. And again, you can see the thyroid, you can make out the tracheal cartilage, and you can usually see the trachea, although there are these acoustic reflections there, as you can see on the slide, which can make identification of an air-filled structure using ultrasound quite challenging. Okay, so we need to do a tracheostomy. How are we going to do it? Are we going to ask a surgeon to do it, or are we going to do it percutaneously? So it's certainly worth reflecting that when it comes to surgical tracheostomies, in an emergency, the time to do it is when you first think about it. But we're talking about the elective situation here. And so what we know is that outcome data and complication rates are broadly similar. For a surgical procedure, usually if the patient's in theatre having something else done, like a head and neck surgical procedure or something around the neck, then yeah, it's easy enough just to get our surgical colleagues to perform the tracheostomy while they're at it. Often for cancer, there are particular steps you want to go through when you are performing a tracheostomy, and so that's quite important. In patients who are obese, particularly ones who you cannot palpate the trachea, they're often a patient group that I would ask our surgical colleagues if they can help us with the tracheostomy. If a patient's got a neck injury or broken C-spine, for example, then a surgical tracheostomy may be less likely to cause movement because we don't need to hyperextend the neck like we do for a percutaneous tracheostomy. If there are vessels in the way and possibly the thyroid in the way, then maybe we don't want to just be sticking a needle through that with the percutaneous approach. And so if there's a big vessel in the way, particularly if it's an artery, I'll ask a surgical colleague because they're trained to dissect, to locate, and to tie off and move vessels that are in the way. And finally, if the tracheostomy needs to be done under local anaesthetic with the patient awake, typically we do that with a surgical approach. It is possible to do percutaneous awake tracheostomies, but I think a surgical approach is more established. One of the big advantages of a PDT in the ICU is the logistics. Moving a patient who's critically ill to an operating theatre is a challenge for the patient, for the staff, and also the logistics involved in trying to find a theatre that's free, a theatre team that's free, and an anaesthetist that's free, and a surgeon that's free. And so just deciding this patient needs a tracheostomy and getting on and doing it is a huge benefit of the bedside approach. I think the jury's out on coagulopathy. I certainly think from a tissue trauma perspective, if you are dilating the tissues and not doing so much cutting and stitching, then there's a tamponading effect from a percutaneous tracheostomy. And so for our patients with coagulopathies, particularly patients on dual antiplatelet therapies, then I think a percutaneous tracheostomy is probably safer, although there's no real data to support that. There's usually less of an incision, but at the end of the day, a stoma is a stoma. But sometimes in certain patients, a smaller wound can be advantageous, both cosmetically and practically. There are different ways of entering the trachea. From a surgical perspective, slit incisions are often horizontal or vertical. More commonly, surgeons will perform a window. And sometimes a Bjork flap is required, named after the thoracic surgeon Viking Bjork, which is one of the best names, I think, in medicine. If you are doing a tracheostomy and you put sutures in, either stay sutures to pull the trachea anterior and to open the stoma, or a suture that holds the Bjork flap ramp to the front of the skin, then you need to explain to anyone who's going to be looking after that patient what those sutures are for and what they do if you pull on them. Because in some situations, pulling is good, and in some situations, pulling is bad. And the bedhead sign, which we'll review later, is an important place to make those entries. Is the patient ready for a tracheostomy? Well, I think there's no absolute cut-offs because different patients vary, and the urgency of the tracheostomy may dictate that you would perform a procedure on one patient when you wouldn't perform it on another. So I think about 50% FiO2 is about where you want to be, ideally lower. If they're on much above 50%, I'd be a little bit apprehensive about the suspension of ventilation and the changes in airway pressures that we're going to be putting the patient through. You want them on moderate PEEP and moderate inspiratory pressures, but I don't have any particular values in mind, as I say, because things change a lot. You want the patient to be cardiovascularly stable. If the patient has a head injury or is any concerns about intracranial pressure, then you want to check you can lay them down and put them in the position for tracheostomy without causing undue rises in that intracranial pressure. And you may want to consider, has the patient had an appropriate trial of extubation? Are we jumping straight into a tracheostomy, or is this something that we've considered? And certainly some of the reviews of tracheostomies that we've performed, particularly in our critical care patients, have suggested that we're perhaps not giving a trial of extubation to some of our patients who end up with a tracheostomy. And I think with the development in respiratory physiotherapy and other techniques we have for keeping patients off ventilators, like non-invasive ventilation, cough assist, things like that, we certainly extubate patients that we probably wouldn't have extubated maybe only 10 years ago. And so I think it's always worth just thinking, is this the right thing to do on this day for this particular patient? In the pandemic, there was a bit of literature written about apnea trials in terms of trying to work out, is the patient ready to tolerate the apnea necessary? Certainly my early practice in percutaneous tracheostomy, I didn't worry so much about suspending the ventilator, but in the COVID pandemic, it made us all think a lot about protecting staff from aerosols. And so suspending ventilation for at least the key steps or possibly all of the tracheostomy procedure when there's a hole in the airway and you would normally want to ventilate the patient is quite important. And so switching off the ventilator and seeing if the patient tolerates apnea is something to consider in certain circumstances. I certainly wouldn't mandate it, but if you're worried about suspending the ventilator, particularly for a patient with highly infectious respiratory disease, then you want to check that they're going to be able to tolerate the procedure before you do it. The time to find out that they will not tolerate the procedure is whilst the neck is open, the patient is hypoxic, and you're desperately trying to re-establish ventilation. Let's quickly review some indications and the practice for surgical tracheostomy then. So nearly always occurs in an operating theatre, but not always. I think airway management with any tracheostomy is really important, and close communication with your anaesthesiology colleagues is clearly critical. We'd often start with the ET tube in its sort of ventilation position, which is the image on the left-hand side. And then for a surgical tracheostomy, you can either advance the ET tube beyond the proposed insertion site, so advancing it down towards the carina, obviously being mindful you don't place the tube down the right main bronchus, or you can pull the tube back. Either approach is fine as long as the anaesthetist is experienced and understands the risks and benefits from each one. It's a more secure airway if you advance the airway, and obviously more precarious airway if you've just got the ET tube just sitting through the vocal cords. But having the tube out of the way means it's less likely to be damaged and is going to be out of the way for this surgical procedure. You can perform a tracheostomy with a laryngeal mask airway in situ, either a surgical tracheostomy or a percutaneous tracheostomy. And here we're just showing on the diagram that it's possible to place a bronchoscope through the aperture of a supraglottic airway device and to visualise what's going on. You need to make sure that the patient has an appropriate seal, that their airway pressures aren't too high and their aspiration risk is appropriately low. But it is possible, and you do get a pretty good view if you put a bronchoscope down there afterwards. There's not many ICU patients that you would do a tracheostomy on that will manage with a supraglottic airway device, mainly because we're doing the tracheostomy because we can't ventilate them so well. And so that usually mandates an endotracheal tube with a cuff on the end of it. Moving on through the surgical procedure, skin incision, blood dissection, and then exposing the pretracheal fascia. Here we've divided the thyroid isthmus using usually bipolar dithermy. Stay sutures in place. These are all placed around the second or third tracheal rings, and then we cut a window into the trachea itself between the stay sutures. And the purpose of the stay sutures, as I said before, is to elevate the trachea anteriorly and to open the stoma, which can help to secure the stoma and help if we need to change or replace the tube, particularly early on in the patient's course before the stoma becomes established and mature. And then you basically place a tracheal tube straight into the window that you've just created, coordinating that with the anaesthetist and suspending ventilation as necessary. Once the tube is connected to the breathing circuit, you need to mark any sutures very clearly. You can see in this image here, it's very clear that these are stay sutures, and make it clear on the bedhead sign what their purpose is.